Hi, everyone. I'm Brina Holmes, pediatrician over here at the Vermont Child Health Improvement Program. We're excited you're joining. We're going to let the computer do its magic to let you in, but I'm seeing a nice chunk of humans already at the top of the hour here. We are grateful you've chosen to join us. This is our second call in our very exciting and fun birth certificate quality improvement project that we're working on together with you. And thanks for coming. You're welcome to eat your lunch. Take care of your needs as you listen to some great experts today. This is a real nitty-gritty brass tacks kind of call where we're going to get right to it on these variables. We are so lucky that we have Michelle Osterman and Joyce Martin from the National Center for Health Statistics with us. Give a little wave there on the big Zoom, Michelle and Joyce. And, thinking that maybe they show up this way for all states, which I'm sure they're willing to do. We just found out that Michelle has been around for a long time, 15 years. This is her first time talking directly to a state team about this type of work. So, and she's our perinatal expert today. We're also so grateful that Marge Meyer's here. Hi, Marge. Marge is our local and amazing expert, maternal fetal medicine professor and vice chair of OB, and she's going to take us through some of the clinical side of this. So, next slide. Unless, oh, I was going to say, Angela, if you want me to do it, I can as well. So I love to make this joke. How many Zoom calls are you on when people are still speaking when muted? So I think the reminder slides are terrific. We love chats. We would love for you right now to put in your name, your role in the hospital, and which hospital, so that we can do that record keeping. We hope there's a nice interactive chunk here, and we'll like you unmuted for that. I hope those that need it know how to do captioning. And it's a quality improvement team. So we need to know at the end how this went for you. And please, just as you're leaving, the evaluation will be available and we would love to hear from you. Next slide. Okay, we're going to start by really bringing it all home by thanking you for your participation and kicking off the fall. There's that new energy in the air that we're going to keep getting to the matter at hand here. We're going to show you the progress that we're making on the baseline data. We're about halfway through our baseline. We had a change in staff, and we are still trucking along. And then we're going to dive right in. We're going to look at the indicators that we've picked to improve as a state. We're going to make sure that you know what you need to know in order to keep attending to those indicators. And then we're going to make sure we have a plan for the next time together. Next slide. Okay, we have all of our hospitals in this project. I have been around a long time and I don't know that that's ever happened. We are so grateful. I hope you see your name on this slide, but it is a wide, it's the geographic diversity of this great state, and we're thrilled. Next slide. Here's the thing, you guys. This is all about the team and what we have asked of you and you have done. We would like a clinical lead and we would like a health information manager and those two people to know each other, to take ownership together of this year and to recognize that there is skill and knowledge on both sides of this important data set. And if we know one thing in Vermont, it's that we do really well when we have relationships with the people that we work with, and getting to know each other and understanding what your jobs are would be of great help to the ongoing effort to understand the birth experience in Vermont. Next slide. Okay, I'm a big jargon buster. This team is having a lot of fun because we love our acronyms and we love our shorthand, and there's a lot of opportunity to stop and say, wait, what is that? So the electronic birth registration system is often shorted to the EBRS. So that side on the health information side, the informatics folks, I'm sure you just call it EBRS, but I'm sure there are clinical folks on this call that have no idea what that is. So this is the state of Vermont's electronic system to submit the birth certificate data. This is the Cindy Hooley. I should also have shouted out my great friend Cindy from the health department is on our call. The National Vital Statistics System, the NVSS, is an intergovernmental sharing of system for the sharing of data at the national level. And I really want to get us together on this mission critical thing. We know so much about the birth experience in Vermont, pregnancy and birth and postpartum because of this data. So all of our efforts, your efforts in particular, are in service of a really important data set that helps us determine so many things, including where to put funding and where to put our efforts. And then our friends today on the call, Michelle and Joyce, work at something called the National Center for Health Statistics, which is at the Centers for Disease Control and Prevention. And that is the group that look across many, many data sets to provide timely and accurate health statistics for our country. Next slide. Okay, so we picked these 11 measures. This was just kind of a mixture of things that have been noted to be a little bit discrepant between a chart and a birth certificate. We wanted to span across pregnancy and also the baby's experience. And then we wanted a few sort of general public health interests, things like breastfeeding and the payer, the insurance. So there was not some massive longitudinal effort here. We just got together and a bunch of people that know a lot about this picked these 11. And the whole project is just looking what is the difference between what goes into the electronic health record as a chart review clinical observation and what actually do we pull out of the birth certificate from the data that you've entered? Where is that discrepancy? And we knew it was discrepant. So this is not a big punitive space. We just know this is what happens with data and data entry. Okay, next slide. So here's what we know so far. We've done 5 out of 11 hospitals. Almost all the indicators come in lower with fewer on the birth certificate side, meaning that there's more clinical information that's not being found and registered into the birth certificate. The 2 outliers on that are on the top there, breastfeeding. So a little bit more breastfeeding attributed in the birth certificate than there is in our clinical record finding. And I guess the insurance one, which is 10% more noted that there's private insurance when they look in the birth certificate record than there is when you look in the chart review. And what I love about quality improvement is I have no explanation for that. I'm just noting it. And we're all just wondering about it. But all the other indicators, there's more information in the chart than there is showing up in the birth certificate, meaning we have some work to do to get accuracy into the birth certificate. Does that make sense? Okay, next slide. And here is it stated a different way. It's fun here. We love data visualization. On the left, it's raw numbers. On the right, we tried to do it in the bar graph. So if you look down this list, CR stands for chart review, BC stands for birth certificate. Pretty lined up, except for a couple of really big outliers. Go all the way down to premature rupture of membranes. In the chart, it was 23 charts. Birth certificate only mentioned 13 of those. So we're way off on that one. And then if you keep going down, you can see for private insurance, the chart said it was 105 of our records and the birth certificate said 116. That's significant. And then in the assisted ventilation after delivery, 27 times so far in the chart review and only 10 times noted in the birth certificate. So there's the project. That's where we're going to do our efforts. And we're going to go to next slide. Okay, so just to go a little bit deeper on our esteemed guests today, we're so grateful that Michelle is a health statistician who knows the most on all of this about perinatal data. And she's going to take us through on the pediatric side. But first, we're going to have our very own Marge Meyer, Vice Chair of OB, Division Director for Maternal Fetal Medicine at UVM, and a Professor of OB/GYN and Reproductive Service. Marge is going to take the obstetrical side. And then I wanted to note that Joyce Martin is here as well, and she is excited to hear your questions. She is part of the national team with Michelle. So turn it over to Marge. Next slide.
Thanks, and I'll keep this pretty straightforward. I'm super happy to have the National Birth Certificate people here. I was chatting with somebody about some of the issues and definitions, and I'm super glad to hear that there's some revisions under the way. So mostly I was just talking about pre-pregnancy diabetes and gestational diabetes and how you know which is which. And mostly I just did this very pragmatically for the coders. So next slide, please. So basically, pre-pregnancy diabetes is a diagnosis that's made before pregnancy. Gestational diabetes is during pregnancy. This seems like it should be straightforward, but it's actually really not. And I'll have a slide just to talk about how you can figure those out. But in general, there are well accepted ACOG definitions for both of these that I'm always happy to help any hospital go through if they don't understand or have questions. Next slide, please. So in terms of just documentation, this is again where the places are to look. The presence of pre-existing or gestational diabetes should be a part of the history admission H&P, and that's usually where you would find it. The determination and the diagnosis of these should not be done by the birth certificate clerk, but should be done by the people taking care of the patient. And if you're not sure, you can always talk to the OB providers. And clinicians will know. And sometimes we have to be the ones that just ultimately make a classification if it's unclear, but it should really be in their H&P. It's not usually something done at the time of their admission to the hospital for delivery. It's usually made before then. Next slide. So basically, in terms of just how to document, from the providers that are on the call or information you can give to your providers, every hospital can decide where they want to have this particular documentation noted, but for good clinical care, it should be in their H&P and on their problem list with a plan made for intrapartum and postpartum care. The best practice, therefore, would be to document in the H&P and to specify at that time, as you've been following the patient, whether or not it's pre-existing versus gestational diabetes. And then document this in whatever area you've mutually agreed upon with your birth certificate abstractors. So I'm not saying the document should be in the H&P, but I think every hospital needs to decide between the clinicians and the abstractors where the data is going to be so you can make sure it lands there. So the birth certificate abstractor responsibility is really going to be to look in this area under pregnancy problems, to identify it, and to abstract the data from that. Next slide. And really for hypertension, it's a similar thing. And it can even be even more muddy because this issue of pre-pregnancy hypertension, which is chronic hypertension, and gestational hypertension can also be a tricky one. Again, though, it's not the abstractor's job to figure this out. The providers, again, should know and should have in their H&P as they're taking care of the patient so that they know whether or not the patient has chronic hypertension or gestational hypertension or preeclampsia. Next slide, please. And again, hypertension actually has a very specific diagnosis. This is not exactly correct for pregnancy. There is a very specific definition of 140/90, less than 20 weeks. And I will tell you, it's very specific this week, but I think that that blood pressure cutoff is probably going to be down, probably going to be lowered, which is consistent with the national guidelines, but that's where it is currently for ACOG. So pre-pregnancy hypertension, even though according to the birth certificate data, it says prior to the onset of pregnancy, the reality is that's not consistent with ACOG. And again, I do not want people to get worried about being in the weeds. The OBGYNs and the OB providers should know how to diagnose chronic versus pregnancy-related hypertension as ACOG specifies, and they should make sure that that diagnosis is very clearly marked in, again, some pre-specified area, in usually the H&P. Gestational hypertension, of course, is the onset of hypertension after 20 weeks gestation. The cutoff is 140/90, but you shouldn't have to check both. Next slide, please. So from this, one important thing is patients can have both pre-existing hypertension and preeclampsia. So I know that slide before, the instructions said, don't check both. We can ask the birth certificate people. I would probably check the most severe one. That would probably be preeclampsia. But many people do have chronic hypertension with superimposed preeclampsia. But work with your abstractors to determine where this is going to be, where it's going to be noted. Document in the H&P or whatever, or in a note at the time it's developed. Again, one of the other issues is people with chronic hypertension might develop preeclampsia over the course of their hospitalization. This is why it's so
Hey,
important.
Marge.
Yeah.
Marge, can I just interrupt? This is such an important point, and Heather's asking in the chat exactly this question. So, Heather, I think you're wondering how to document in the birth certificate, obviously not the record. So, Marge, you've just said something important, and I wonder if Michelle wants to weigh in as well from the birth certificate side. So, how does a health information person decide? And if it is severity first, that needs a clinical conversation. So I'm curious, Michelle, if you have a reaction to that particular indicator.
That's a tricky one. Joyce, if you have anything to say. I'm looking in my guide.
Let me get myself off mute. My understanding is just what you said. If preeclampsia would supersede hypertension.
Okay. I mean, I think we just need to do our best on that one. Thanks. Okay, keep going, Marge.
Yeah, so just to clarify for the people that are the birth certificate abstractors, it is fair to say when you see preeclampsia, and certainly eclampsia, this is what you should probably code. Again, the diagnosis of chronic hypertension, I think that the clinicians are going to use the definitions that they're supposed to, and I think that if you document it, what the diagnoses are, that is going to be sufficient. But you should document this in an area that's mutually agreed upon with your abstractors, and again, with specific attention to knowing that people will develop preeclampsia later in gestation and later in their hospitalization. So make sure that this mutually agreed place, maybe a discharge summary, maybe it's the last note that people have before they're discharged, where that's going to go, and make sure the providers put it there. The abstractor responsibility, again, is going to look in this designated area for these problems. My guess is for this one, the discharge summary would be the best place, honestly, for all of them. But work with the providers at the individual hospitals. And note that preeclampsia is a form of gestational hypertension and that people can have both. Next slide, please. Induction of labor. This is another one. Should be straightforward, but perhaps not so much. Next slide. So again, these are the instructions from the birth certificate guide in terms of using things before labor began. Just as a note to your birth certificate people, the reality is the definition of when labor starts, not so easy. So maybe this wording could probably use a little bit of a touch up. It does specifically say it does not include augmentation of labor. And I will, the next slides I think will clarify it to somewhat. But generally, the good news is usually this is easy for both the clinician documentation and the abstractor documentation. You're going to look at the admission note, and it's going to say admit for induction, or it's going to say admit for labor. And this is going to hit that 80-20 rule. 80% of the time, this designation in the H&P is going to be easy, straightforward, and correct. When you say when it says admit for spontaneous rupture of membranes, which is the same as premature rupture of membranes, with no contractions, that's an induction. And admit for spontaneous rupture of membranes with contractions, and then oxycosis started its augmentation. So go to the next slide. I'm gonna help break this down because, again, you're gonna be very dependent on provider documentation. And again, you're seeing a theme here. The providers need to document in a way that the birth certificate abstractors know what's going on. So document the H&P, which I think most people do now, why people are coming in. And it's usually, they're either going to be induced, they're in labor, or they have ruptured membranes and they're not in labor. And I believe that almost, this probably is what most people do already. In the H&P, it should say if induction versus augmentation is planned, as most people know, augmentation with oxytocin will not always be in an H&P because it's going to occur at a later time. It's going to have to be in a discharge summary. The good news is most of us have a labor and delivery summary that does specify this. It is the role of the provider to know what your documentation looks like. It should be included in that. That would be normal routine OB care, including the methods of induction. And these are generally found in your delivery notes. If your automatic delivery notes, now, however you're documenting them, does not include these things, you should probably modify them to do so because it's good medical practice. And it would be good if you could put in a discharge summary if they were induced versus augmented for the birth certificate abstractors. So the abstractor should look in the H&P. That's way they'll know when people come in. Are they being induced? Are they in labor? Or do they have ruptured membranes? With no labor, I would say, again, decide on where you want to document these things. The discharge summary should have that same language. And it really should be in a delivery note. And you should think about modifying your delivery note if it's not, so that it has this information. And with that,
Hey, Marge.
a minute to look in the chat.
Yeah, I can help with that. I'm gonna do the chat for you so you can keep rolling. So Kate's asking, what if multiple induction methods are used?
I think you can add in all of them. I can't remember. Some of them are old that we don't use anymore. You can do a multi-check for that one.
Great.
Okay, next slide. Augmentation of labor. Next slide. Augmentation and stimulation after labor has begun. Again, just so that the birth certificate people know, I would say after the onset of painful uterine contractions, because really the definition of labor is they have to have had cervical pains, but sometimes you augment somebody's labor before they have it. It's kind of a weedy OB thing, but just so you know, this language is kind of contributes to some of the confusion. But basically don't include this if induction of labor is performed, because sometimes people have kind of a mix. We all know, we clinicians know that, but if they came in not in labor and you gave them a bunch of stuff to start labor, that is an induction. Next slide.
Hey, Marge, Kate also wants to know with the quality chats, do you also mark all? Charts, I think it means, but.
I don't know what you mean by quality charts, Kate. Oh,
Oh,
stats.
stats.
Oh, yeah. Mark as many as what you use. So again, this is all about provider documentation. Again, it should be in the H&P. If you're planning on augmenting them then, most of them are not going to be in the H&P. They're going to be sometime later. You do not want your person, your abstractors to have to look at every note. So it needs to be in the delivery note and ideally also in the discharge summary. And ideally, if you put everything in the discharge summary to be kind to your abstractors and to template your discharge note, that would be the kindest and best way to get good data into your birth certificate. And I will just remind you that you also have an added incentive to get this right. Because when you guys get your data and you say, this doesn't sound right, you should hold up the mirror to ask why that data might look a little funny. Because oftentimes that's going to be kind of where the issue is. So just make sure, I would recommend actually making sure your discharge summary has to work with your birth certificate people, make sure that you know exactly where to tell them to look for everything. I personally would recommend H&P, delivery summary, and discharge summary. 3 possible places, but you can map every single element. You should be able to map every element in the birth certificate to those 3 documents and to be able to tell them which one each one is in. Again, the abstractor responsibility is just going to be to look in those areas that you've agreed on and ideally put it in the delivery note as I talked about. Next slide, please. Premature rupture of the membranes. Also, this is not the best language that we use now for ACOG, but it's what we have. And this says prolonged, but it doesn't. This is the only place, and actually this is a question for the birth certificate people. This is the only place that it has a time limit. Other places in there don't. So go to the next slide. It might be in there. Oh yeah, it says prolonged, but this just says premature rupture of the membranes. Those are 2 different definitions. One is premature rupture of the membranes, where you start oxytocin. The other is a time element. And I've not looked at the birth certificate to see if it specifies greater than 12 hours. And I meant to look that up before. So I do think that that's an important nuance. It means that you have to put what time the patient ruptured their membranes, and it also means that the provider, when they start, needs to put in that as an indication and the time. Next slide.
And Marge, I just put it in the chat, but from our early review here, that premature rupture indicator has a big discrepancy.
And it's
The biggest of
probably
all.
because of that. And again,
Yeah.
I think that 12-hour nuance is a little bit weird because it's a different diagnosis than the title. Oh, Joyce?
Yeah, Joyce has
Hi.
her hand up. Yeah,
Hi.
thanks.
For whatever it's worth, these items have been dropped from national reporting because we could not get quality data based on how they're currently worded. We would really appreciate, it's an important item, however, and if you have thoughts on how we could, for the next revision, better capture this, it'd be greatly appreciated. But it is a problematic item.
Yeah, Joyce, yeah. Well, as Brina's not surprised to hear, I do have thoughts about that. And I talked to somebody at the National Center for Health Statistics. I can't remember. I was emailing them because I think you have the same problem with your diabetes and your hypertension diagnoses. They just need updating. It's okay. And yes, now that you mention it, I remember that I heard that you had taken this out. And you know, it's a good example of something that is important, but very difficult to document in a way
Right.
that's
right.
consistently and easily abstracted.
So
Yeah, well, I
it's
think it's
possible,
oh, go ahead, Joyce.
it's possible that it would be very difficult to collect this with good quality on the birth certificate.
Yeah,
Diabetes and hypertension are underreported, as you've noted, but I think not in the same category as are these items.
yeah. And then diabetes, it's more the pre-existing versus pregnancy related, which
Right.
is, I think,
Right.
important, but
Yeah.
you just need to dust up on those definitions.
Hey, Marge, I think that's a wrap on the obstetrical side. If you go to the next slide, I did want to note, I can see the importance of relationship even in a hard indicator like this one. So if And I'm really thrilled with how many clinical leads we have on this call right now, as well as HIM leads. If you can find each other and ask how you want to do it, we might be able to have our own little mini QI on this. And it's super helpful to hear that the national team has dropped it. Okay, this is your
I'm
chance,
happy to
team.
help anybody if you
Yeah.
can't figure it out.
Great. Yeah, so Marge is here. So here's that was great use of the chat. Thanks for Heather and Kate for doing it that way. If folks want to unmute and ask, we have a few minutes on the OB side before we head into the baby. The baby's about to be born. Anything else about those or other things that are making your jobs hard or confusing?
There's a
Or
quick,
Jenny, yes, go.
I just didn't understand what the problem is with the, I wasn't clear about what the problem is with that last one with the prom. Why is that a problem with the, why do you think that's a problem? And I guess I'm not, the definition that is there seems clear to me, but so that makes me think I'm not understanding because it's clearly a problem. So you're saying that prom is if it's greater than or equal to 12 hours before labor starts. So it seems like, is it hard to tell when labor starts sometimes, or because of that, because we don't actually tell all the time? You know, we don't check her every 5 minutes. Is that why, or why is it complicated?
Just briefly, I'll tell you, it's because of at first exactly what you said. It's hard to know exactly when labor starts, and so labor is not a great term for any of it. Better onset of painful uterine contractions. But really more importantly, is it's very difficult. Most places don't have a discrete place for rupture of the membranes, because people rupture their membranes at home. They might have stayed at home for a while or whatever. Documentation about what that time is. And if people know, they'll be like, I had some trickling at 3, and then maybe I had another gush at 5. So if somebody's just making up what that time is, number one. And second, again, to put it in an abstractable place, to know that it's greater than 12 hours, as you're right, until what? The onset of contractions, documented painful contractions with cervical change, which is the definition of labor. It's like, it's a very fuzzy time thing. And just, we don't document all these things very discreetly in terms of this 12 hours. So it's just a little wonky. Perhaps a better indicator. It depends on what you want to go after, right? I don't know why the National Center for Health Statistics would want to know, but I would want to know for neonatal sepsis risk. And so perhaps a better thing would be rupture membranes to delivery time. That you can measure and you can tie to an outcome, for example.
Sounds like a project for next year, Marge. Hey, Kate wants to know, what if they opt to start PIT prior to that 12-hour mark? Does that change how
Yeah,
you?
see, that would be the other problem.
Yeah.
That's why I said whether or not you caught the nuance of the 12 hours or if they just had premature rupture membranes, especially now because of the infection data that we know about. Most people don't wait 12 hours, they just get things going. And so again, it turns into a not particularly meaningful variable.
Yeah. It's funny, quality improvement is such a fun science because if we could have asked our national team about the indicators we picked and they would have told us not to do this one. But we're doing it anyway. And the reason we're doing it is because of the relationships, because if you want to just get together and decide how you're going to try to measure it, it's going to improve all the other indicators as well. That's what we meant to say at the beginning, or I did. These 11 are proxies for the effort. It's not specific, like we only think these 11 matter. Does that make sense? We're really just trying to have something to measure to show the impact of you guys hanging out with each other. Okay, I am thrilled to now get Michelle in the hot seat to turn us into here comes the baby. Baby's here now. And thanks, Michelle. Take it from here.
thank you. So we're going to start with the breastfeeding question. is child being breastfed at time of discharge on the child stat tab. Next slide. So the question, is the infant being breastfed at discharge, is defined as information on whether the infant was receiving breast milk or colostrum during the period between birth and discharge from the hospital. Breastfeeding refers to the establishment of breast milk through the action of breastfeeding or pumping, and includes any attempt to establish breast milk production during the period between birth and discharge from the hospital. Next slide. It also includes if the infant received formula in addition to being breastfed, but it does not include the intent to breastfeed. So why does this item matter? It's used to track breastfeeding levels, which have public health importance, and to better target funding. Next slide. The instructions for this item are to check yes if the infant was breastfed or received breast milk or donor milk at any time before being discharged from the hospital, and check no if the infant was not breastfed or did not receive breast milk before being discharged from the hospital. Next slide. The next item is, was the infant transferred within 24 hours also on the child stat tab. Next slide. The definition of this item is the transfer status of the infant from this facility to another within 24 hours after delivery. And this item matters because it's used as an indicator of risk status for the infant and of the appropriateness of care. Next slide. The instructions are to check yes if the infant was transferred from the facility to another within 24 hours of delivery, and then enter the name of the facility to which the infant was transferred. If the name of the facility is not known, then enter unknown. If the infant was transferred more than once, enter the name of the first facility to which the infant was transferred. Next slide. The next item is assisted ventilation required immediately following delivery on the medical health tab, and it's part of a checkbox group of items for abnormal conditions of the newborn. Next slide. The definition is infant was given manual breaths for any duration with bag and mask or bag and endotracheal tube within the first several minutes from birth. It excludes the free flow or blow by oxygen only, laryngoscopy for aspiration of meconium, nasal cannula, and bulb suction. And this item matters because it's used as an indicator of the severity of the condition of the newborn at birth. Next slide. There are no special instructions for this item outside of the general instructions for the whole checkbox, but the key words and abbreviations include those like bag and mask ventilation, intubation, PPV bag, IPPV bag, etc. Next slide. NICU is another abnormal condition of the newborn. Next slide. NICU admission is admission into a facility or unit staffed and equipped to provide continuous mechanical ventilatory support for a newborn. This item matters because it's used to assess the appropriateness of a costly resource in correlation with other data items. Next slide. The instructions are to include NICU admission at any time during the infant's hospital stay following delivery. Do not include units that do not provide continuous mechanical ventilation, and do not include well baby nurseries or special care nurseries such as level 2. Do not include if the newborn was taken to the NICU only for observation, but was not admitted to the NICU. Next slide. Then the last item that I will cover is the principal source of payment for the delivery. Next slide. The definition is the primary source of payment for the delivery at the time of delivery, including the options of private insurance, Medicaid, self-pay, and other, which includes Indian Health Service, Champus, or TRICARE, other government sources, or charity. This item matters because it is one of very few and probably the best proxy for socioeconomic status that's on the birth certificate. Next slide. The instructions are to check the box that best describes the primary source of payment for this delivery. If more than one source of payment for delivery is recorded, choose the source that appears to pay for most of the delivery. Check the source of payment for the delivery, not the payer for the newborn care or prenatal care if they're different, and check other. If other is checked, then specify the payer. Next slide. If the principal source of payment is not known, enter unknown in the space, and then if unsure what source of payment a given insurance falls under, because we know there's some confusion with this, then please check with the billing office so that it can get in the right category. I think that's it for
Yeah.
my item.
Thanks, Michelle. Okay. So, couple things. So grateful for Marge and Joyce and Michelle. Second thing, Julie just put this in the chat, but these are the variables that we identified to pay a little bit of attention to, but we are wide open to any variable that you're struggling with. And this would be a good time to ask because we've got these experts on the call. So don't feel constrained by these 11. I did want to note, as I did in the chat, that the assisted ventilation on the newborn side is also showing up pretty discrepant in our early chart review. So premature rupture of membranes has some issues, and the assisted ventilation likely because of Michelle's description. Interesting, Heather. I don't know. So Michelle, is CPAP consider assisted ventilation? I think so, but
It is, but it would go, we have the second item, assisted ventilation required for more than 6 hours. That's where CPAP, should it be applied for that many hours, would go.
got it. Does that make sense, Heather? Interesting. Okay, and Kate, the GBS status is not flowing into Epic. Say more. Unless someone on the call can shorthand that. Digging through slowly to see all the things that aren't flowing. Okay, do you mean,
Hey, just let us know. Just bring that to Jody and we'll figure it out, because ours does. And so it might be a weird lab thing.
great. I think Jenny and Joyce have hands up. I don't know if that's old or new. So Jenny, do you have another question?
I do.
Great.
Regarding the breastfeeding before discharge question, does that mean before transfer or discharge, or just, so if they're transferred, does that mean discharge from the other hospital? Or just from your hospital when they're transferred, is that your discharge? So if they're a newborn and they're transferred and they're not going to be breastfeeding because they're sick, but then they go to the NICU and then they are breastfed. So we wouldn't know the answer to that. So are you saying we should just say, or just consider transfer the discharge?
Right. Yeah, for infants that are transferred, the transfer is considered the discharge, because you can't, it's too hard to know what happens
Right.
Right.
with that other facility.
Just wanted to check on that. Thanks.
It's a great question though, Jenny. So that one drops right out, right? Because sick babies haven't even tried to feed yet. Yeah, I'm with you on that one. What else is it like for you? Oh, NICU admission, is that just our hospital or when transferred to another one? Michelle.
If the infant is transferred, then that's where the reporting stops. If the NICU is in your own hospital, then it should be reported as NICU admission.
Unless they're just observed. Remember, Michelle said
Right.
that one caveat. If they go upstairs, downstairs, but not admitted, they're just observed, that doesn't count. Again, because we have to go meta here. What are we trying to fix? Why do we need that data? And it's about the level of care, the how ill the infant is.
Can I
Is
just
it-
oops. Can I add something just for Tina at Gifford who asked the question? I think in terms of NICU admission, I can't remember if Gifford does NICU up to UVMMC or the one in Nepquin, but that would be the two options.
They go to
Julie-
Dartmouth.
Sorry,
That's
Yeah.
We transfer to
This-
either UVM or Dartmouth.
Yeah, a lot of places go either one.
Important question. Okay, and Marge is gonna go to take care of patients. Why we love that, real life Marge, if there are any questions. Yeah, so we're here for you. Let's do some of the wrap-up slides, Julie, to show this is a very well-worn path for all of you out there trying to figure this out. Oh, before I go, I want to get Marissa's. Infections present and or treated during pregnancy. If a mother was not tested for one more infection, how do we provide accurate response in the EBRS? Oh, we lost Marge. What do you think of that one, Michelle or Joyce?
If she has it, I mean, if there aren't test results, then you can't report that she had it. So
Okay. Marissa, if that's not what you're asking, feel free to unmute. I love chats. Something we see on the parents worksheet is previous outcomes.
Hello. My question is, sometimes we have mothers who have not been tested for chlamydia or whether it be hepatitis, and we hold when they haven't been tested for one or more infections that we check off none of the above in the EBRS system. Would that be putting down not the correct information, or should we still check of any? How would we go about this?
So Michelle, I think the question
So we
is
were told-
is there not a box for not tested? You either have the disease or you don't, and saying they don't have it might not be accurate because they actually weren't tested.
yeah, there is
Is that-
not a box for not tested. If
So we have, so on the EBS, we have gonorrhea, syphilis, chlamydia, hepatitis B, and then we have none of the above. What our hospital has been doing, if they have been tested for everything other than chlamydia, what we then do is we select none of the above.
right, and if she
Or we
presented
leave
with
it, or we
chlamydia,
leave it.
sorry, if she presented with chlamydia at some point during pregnancy, then that would show up in her chart somewhere, and then you would know. But I think none of the above is appropriate in
Okay.
that
And
situation.
what about some of our births have not been checking off anything? If, let's say, the patient was tested for everything, but let's say chlamydia, they leave that completely blank and they don't check anything off.
Then that becomes an unknown, and I think that none of the above is more appropriate in that situation because she wasn't
So
treated
would it
for
be better
anything.
Yeah, so would it be better to check off none of the above instead of leaving it blank?
I think so. Joyce, do you agree?
Absolutely. Absolutely. That's
None of the above.
more useful information. Yep.
Yeah.
That's right. Thanks, Marissa. And then Cynthia Dunn, I'm going to read what you said, and I might ask you to unmute for clarity here. So something we see on parents' worksheet is the previous out. Many patients leave the dates out. It's touchy subject. Any idea on how to approach this? So the date of what? Of a diagnosis? It's awkward for us to call and discuss with the patient. The other issue we find is how many prenatal visits some patients transfer to us, and well, I'll get to that one in a second. So Cynthia, are you wondering what to do? What happened to previous pregnancies? I think that's what you're asking. Okay,
I don't
that's
know.
a hard one.
Hey, can I chime in?
Yes.
This is Tina from Gifford. So I've had this happen multiple times where I have patients or paperwork has come down to me and the documentation is left blank, or they've marked 1 or 2 or whatever, and there's no dates. I'm going to share something personal with you, and everyone is having been a victim. Having to discuss that is very difficult, and rehash it and bring it back up to memory of a date. I know you might need it for your statistics, but unfortunately, some people just don't want to remember that day. And it's a question, is it really, really 100% necessary for knowing when they had an abortion or if they had a miscarriage or death? I mean,
Yeah.
a death, yes, but
This is Joyce. I would say that the interval since the last pregnancy is important piece of information. Totally understand how that would be difficult information to get from people who've suffered a loss. I'm wondering if that information would be somewhere in the mom's prenatal care records
Sometimes it is and
already.
sometimes it's
Yeah.
not.
Yeah. Well, if it's
Tina,
not there,
I
yeah, I'm sorry, go ahead.
well, no, Tina, I'm just so grateful for you to bring up. I think there's a real art to this. So there's the, you know, the facts and then there's the experience. And we have talked a lot as a team about wishing that the prenatal record was more easy and available to the teams that are in the hospital. And I know there's systems for that that are it sometimes work better if the electronic health record is concordant and sometimes it isn't. So I think your heart and your clinical judgment here is the important piece. And then we can continue to elevate that to find a system solution so you don't have to ask. I really, this is a really important area of just perinatal health that, you know, the patient first and the rest follows. I do want to address your second, or not you, but Cynthia's other point is a really good one. So the other issue they're noting, when you're trying to figure out how many prenatal visits some patients transfer to us and they've had visits at another facility, it's often different from what is recorded on the facility worksheet. That also sounds like a medical record problem that, so if Cynthia, if you want to explain that more, or if it really is that the quality of the record that comes to you is thin, so you're not able to accurately count. Is that right? That sounds right.
Yeah, that's Brina, that happened also when we did the chart review. Actually, it was really hard to track that information
Okay.
because those EHR
Yeah.
are not integrated.
But this is why these conversations matter so deeply to us, is that if you're on the health information side and you know you're really good at your job and you really want to attend to the statistics and the clinical team is telling you what some of the barriers are, you will understand each other better, right? And that's a really beautiful thing in quality, is to say, hey, yeah, and Cindy is really coming alongside you here from state's perspective, often seeing missing dates. And I think many of us know that that's because of the sensitive nature of the data. And then Heather's noting that they have a problem with the last menstrual period date. Some people have no LMP since their last pregnancy or at all, or have an LMP that's not related to the EDD. So part of what we want to come away from at the end of this year is system solutions as well as the local relational solutions, and figuring out how to get electronic health records to talk and have you have accurate prenatal information as you're trying to record what happened in the statistics. So Heather, do you want to say more about the LMP? Because that also clinically is real, you know,
Yeah.
there is no LMP, so you just have to leave that blank and no harm, no foul.
I'm okay with no harm, no foul, or if that's not what you based you know, an EDD on, because sometimes there are months, you know, or at least weeks discrepant from each other. I know in another state where I worked, he simply calculated the LMP back from a due date. So I mean, if it's no harm, no foul for just leaving it blank, I think that's fine. And we can just write unknown or not applicable or whatever. But when we get feedback that like, hey, that you're missing a lot of this sort of stuff, then that's like that's mixed messaging, I guess.
Yeah. Well, I guess that's why we're so happy with this collaborative team, because if it's a rare event and it's not knowable, then that has to feed back to the team at the state to say, hey, we're not out of alignment here. This was not known. But if it was that it was not, we couldn't figure out where it was on the record, then that's the quality improvement opportunity. Do you know what I'm saying?
Oh, for sure. Yeah.
Yeah. So, but if this starts to be a common, you know, this is what we're interested in clinically, is if this is happening 5 times a year that there is no LMP between pregnancies, then, you know,
I mean,
yeah, go ahead.
In my small hospital, I think it's 5 times a month that the LMP is not used for an EDD. Like, there's a reason we do early ultrasounds, and it's because in a fair
Right.
percentage of cases, it's not accurate for predicting a correct gestational development.
No, see, that's awesome, Heather, because that's exactly what the national team and Cindy here in Vermont are. We're seeking that level of feedback because there is a tweak coming, a slight uh, and you guys all, I know a lot of you met with our team already to talk through some of the stuff that just doesn't make any sense anymore. So, okay, a couple of things I gotta, some of the other versions of Zoom tell you the order of the hands. I think Cynthia was first, and then I see Kimberly's hand up, and I am aware we're at the top of the hour. So Cynthia first. Maybe we lost, oh, she took her hand out. Okay, Kimberly, last word, and then we're gonna show you a few slides and close this out.
You may have actually just addressed it because the concept was like, why do we care about the LMP in today's current world?
See, now that's the kind of, that's exactly why we're doing this project. Is we've got a gap between what we need or have sought statistically over the years and what the clinical best practices, and QI people like us can hold that. It's messy. We're going to just hold that. So thanks for that perfect last word, Kimberly. Okay, the last few slides are to show you that this national team and this Cindy Hooley over at the health department have so many resources for you, and we want to be available to you in many ways. So Angela, if you can just flip through. Obviously, you know about the worksheets. There is a whole EBRS resource for you. I'm sure you all have it, but it's good for our clinical teams to know that your health information folks are well resourced. Next slide. We also know that using, staff turnover as an example, that we have an opportunity to always get back to what are the definitions, what's the instruction, what's the source, and what are the keywords, and that's also available to you through our friends at the CDC. Next slide. You have free trainings available for anyone new or yourself if you need a refresher, or if you continue to wonder about this and want to do a deeper dive than just this hour. And we really, we know that on the data entry side, it's strongly recommended, required. On the clinical side, it's really just a nice strong recommendation. We think you should know this because it's so relevant. Next slide. And then this is something the VCHIP team's working on. We think it would be fun if each of you had a hospital tip sheet that we can provide everything we've learned from talking with you. It's specific to your hospital. It's diving in a little more on your electronic health record and what we've learned from your clinical teams about where to find things and make your life a little bit easier. So with that, I'm going to remind people on the last slide here that we are doing this ongoing learning series again. We're going to see you on October 7th. And that time we're going to talk about more tools to improve the accuracy. We wanted you to know that on October 2nd, we're also having an office hour. And this type of thing you're talking about today, even, elevating this, we're not using LMP anymore. That's what the office hours are for. So pop on in. You don't have to stay the whole hour. You just come for 10 minutes and tell Julie and our friends at the health department what's, yes, Kate, please send someone in your place always. We love to say that all the hospitals are represented. And then I want to go back up. The red cap is there. I know it's 1 o'clock. Please stay for 30 seconds to do a quick survey, or you can do it on a QR code on the screen. And then because I really like chat, I'm going to go back up to say that Cynthia Dunn did say when we have too many unknowns, it becomes a problem. Even after we search the chart, this data is not always certain. So I want to end with that. I can feel that you have high standards for yourself and you want to meet the needs of this data set, and yet the actual implementation of that is frustrating. So we hear that. That's why we're assembling this team, and we're just beginning. It's only September. So I'm so grateful to Michelle. Thank you for joining us. Thank you so much, Joyce. I think Marge has departed. Just really know that we're here, and we hope to hear from you even before the 7th or the 2nd if you choose to come into our office hour. Thanks, everyone.
Thank you.
Thank you.